Good afternoon, everyone. Thank you for joining today's webcast presented by LexisNexis Health Care, Provider Data Quality, Impacting Satisfaction, Retention, Insight, and Regulatory Compliance. My name is Mary DeCelia with LexisNexis. I will be today's moderator, and on behalf of LexisNexis, I welcome you to today's program. Before we launch into the presentation itself, I would like to go over a few brief housekeeping items. First, today's event will be about an hour long and is being recorded. We will email you a link to the archived recording so you can view the presentation again later if you like, or share it with a colleague. Please disable your pop-up blocker to ensure you have no trouble viewing the slides or links in today's web event. This is an interactive event. Feel free to type your questions into the chat box on your screen. We will address as many questions as possible during the final 5 to 10 minutes of the webcast. If you would like to enlarge the slides, you may do so by dragging the bottom corner of the box. This function will allow you to make them larger or smaller. If you have any technical difficulties during the webinar that I have not covered, press Control plus F5 to refresh your screen. If that does not work, please feel free to reach out using the chat box. And finally, at the end of this event, we will present you with a survey. Please take a moment to complete the survey to let us know your thoughts on today's event. Getting us started will be Rick Ingraham. Mr. Ingraham serves LexisNexis Health Care as Director of Vertical Markets with a special focus on health delivery and payment sectors. A leader in the health industry's insights and analytics, he leverages his 36-plus year career to enable team effectiveness and thought leadership, vision, strategy, product development, and brand awareness. An accomplished public speaker and proven executive relationship builder, he presents senior management experience in the healthcare, insurance, analytics software, and regulatory industries. Joining Rick is Jim Peyton. Mr. Peyton is Director of Strategic Solutions Consulting, serving all LexisNexis healthcare markets. Jim and his team work in conjunction with the sales teams to drive new business development, bringing solutions subject matter expertise into the sales process. Jim has been with LexisNexis for almost 5 years, serving as a subject matter expert with specific focus on provider data intelligence solutions. Prior to joining LexisNexis, Jim worked for Optum, a UHG company, for 6 years in their payment integrity division, where he served as Director of Client Service and Director of Operations for government programs. Now, with all that said, I will pass the presentation to Mr. Ingraham. Rick?
Thank you, Mary. And Jim, I consider it a privilege to be able to collaborate with you for this webinar, as I always seem to pick up some valuable insight during our discussions. Thank you for taking the time away from your busy schedule to get behind the microphone. So everyone, thank you for your time today, and I hope you'll find today's content informative and helpful, but perhaps more importantly, thought-provoking. Both Jim and I are committed to empowering the healthcare community with approaches that both support approved effectiveness and nurture innovation. We hope that today's somewhat one-way dialogue might lay the groundwork for continued conversations, and our direct contact information will be provided at the end of today's session. Within the time boundaries of this webinar, we've got much to share with you. We'll kick off by putting a bit of perspective around the challenges facing the healthcare industry, particularly for health plans, and the need to consider the critical role that provider data fills across the operational continuum of current health plan business models. We'll then touch upon areas for your consideration that we feel might challenge the status quo in your organization or even the industry, but will drive value. We will also suggest important components for any enterprise's provider data discipline. Having described the foundation for provider data capacities, we'll then share with you some nuances around provider data, its definition, breadth, scope, and complexity that we've acquired from years in mastering and augmenting and gaining insight from your most significant asset, data. Please don't be shy about posting questions, and we'll get to them as many as possible toward the end of the hour. So let's get going. As I began to prepare for this session and identifying healthcare challenges that we all address in some form each and every day, I couldn't help but recall some quotes over the past few years that stuck with me. Like when Dr. Brent James of Intermountain Healthcare said 15 to 20% of care is clinically inappropriate. Or when Don Berwick, former CMS administrator, said 1 of 3 American healthcare dollars is wasted, and for the past decade, all wage increases have been absorbed by those costs. And when former Health and Human Services Secretary Sylvia Burwell recently said, whether you're a patient, a provider, a business, a health plan, or a taxpayer, it's our common interest to build a healthcare system that delivers better care, spends healthcare dollars more wisely, and results in healthier people. This is about improving the quality of care we receive when we're sick, while at the same time spending our healthcare dollars more wisely. Now, given these observations, I and many of my colleagues have been actively discussing and exploring ways to really attack healthcare quality and cost and experience long before the Affordable Care Act and now in consideration of the proposed American Health Care Act. No matter the venue, the participants, or the agenda, I keep coming back to 7 challenges along with federal and state mandates that are driving our attention. And they're certainly not for the faint of heart. So let me quickly touch on each. Purposely, I've placed at the top of this ever-going dialogue individual patient engagement and consumerism, the ability to better align information and services and activity focus on the needs of the consumer of healthcare services as well as the payer of those services. There's an overall recognition within the care payment and delivery sectors that the more patient-specific we make our communication, programs, and services, the higher the likelihood patients will become engaged in their health adherence, adopting some as lifelong practices. And evolving care models. Now, I would consider that probably the most disruptive to current business models, though generally recognized as necessary. These are new approaches to provider and payment reimbursement, driven by the need to increase outcomes and results associated with care, rather than continuing payment for services regardless of service outcomes and quality, often referred to as the shift from fee-for-service to fee-for-value or value-based reimbursement. And they may include bonuses or withholdings and penalties in payment as a result of prior period's care performance. And finally, evolving care models. There are new organizational structures for the delivery of health care, often directed at improving care quality, coordination, and results, or business risk sharing. Examples of our care delivery models include, but not limited to, accountable care organizations, patient-centered medical homes, and point-of-care centers. Adding to this trio, discussions are also focused on improving insights, such as personal, mental, and behavioral health integrated views. These will enable the creation of a 360-degree view of a patient care profile, crossing traditional personal medical care to include mental and behavioral health care intersections, and summarizing potentially avoidable health conditions and costs. The recognition that many health conditions or procedures may have been avoidable if proper or more efficient and appropriate care protocols, coordination, engagement, and timing of intervention had followed. An analytic discipline to identify specific stages within care where avoidable conditions arise is growing nationally. And enforcing some of Secretary Burwell's comments, overall health system performance, effectively ensuring that the right medical care is delivered the right way to the right patient at the right time in a more affordable fashion. And clear attention to health data use and misuse. Expansion of healthcare data defined to offer better insight into providers, members, or patients, securing the personal identity of the patient and their care record, and ensuring all appropriate health data is leveraged to ensure improved quality of care and to make more informed decisions. Now, these big 7 should not be viewed in a vacuum separately as the interconnectivity of these disciplines that demand data insight across the entire continuum of the healthcare operational model, let alone the fast pace in which they're evolving. Maybe Charles Darwin's observation still applies, Jim. It's not the strongest of the species that survives, nor the most intelligent, but the one that's most responsive to change. And the more I begin to peel back the onion to explore dependencies for information, core blocking and tackling needed, and to make sure my years in the industry haven't allowed bad habits to keep my own definitions from evolving, I realize now is the time for provider data to be a core analysis point, and therefore it must be accurate and up to date. Jim, what is keeping provider data from being readily applied to these top 7 challenges?
Well, Rick, I think the most important thing to note is that provider data is very dynamic. It's changing all the time. And we know, as you mentioned, that accurate, current, and complete provider data is an essential contributing factor to the challenges many healthcare organizations face today. Put it another way, not having correct, current, and complete provider data is going to lead to ineffective solutions for the various issues that you talked about. The fact is, provider data is very dynamic. It's constantly changing. As the slide shows, 2.4% of provider demographics change each month, 30% of doctors change their affiliation, and you have status changes going on all the time with retirements, inactivity, sanctions. And the fact is that there are other factors as well besides the dynamic industry changes, things that are happening within the health plans themselves. In addition, payers are getting provider data from multiple sources. Human errors will creep in, process errors, multiple data files, trying to be connected. The issue is that if you started today with a perfectly clean database, within 18 months, half of your records would have some sort of error. Now, the percentages are certainly powerful, but what do they mean in real numbers? How much provider data really changes in a short period of time? This slide talks about at a week how much changes in the industry. Across the United States, 33,000 primary address changes every week, 3,300 name changes. Phones are changing, fax numbers are changing. So the way you contact a provider is continually evolving. The status of a provider is also changing. We have 86,000 state license expirations each week. We have license statuses that change each week, as well as license qualifiers, DEA, and several other pieces of data. So your data is always changing. Keeping it up to date is going to be a challenge. So in the time it took for us to review these few slides, your data has probably changed. Getting an initial set of data is relatively easy. Maintaining it is very hard. To try to stay ahead of the change that we see is important. I'll let you advance. In this presentation, we're going to talk about some of the best practices that we've honed over the 12 years that we've spent building and maintaining a referential master file of all the provider data, both on practitioners and entities across the healthcare space in the United States. We've learned best practices to build and maintain correct, current, comprehensive data, and we build that into our solution. So Rick, what does it take to get correct, current, and complete a complete view of provider data?
Good question, Jim. I guess if I'm going to provide any advice, I would put it this way. Take a look at how you define provider, and then be absolutely sure your definition of provider data is aligned and supported with adequate data fields, all contributing to that definition. Now, we intuitively know health data is broad and complex, but when you consider the various components and their magnitude, the importance of aggregation, cleansing, and managing data cannot be overlooked. This is our constant focus as we protect, manage, and apply data encompassing our repositories. Repositories that include 1.2 billion medical claim filings and 8.5 million healthcare professionals. Prescriber data, more than 2.7 million healthcare professionals and healthcare organization affiliations, integrated data delivery networks, active HCOs, and 800 ACOs that have more than 4,000 relationships to HCOs and IDNs. This is something to take seriously. Now, during the course of this session, we've got several polling questions we'd love to pepper throughout the day. So let's kick off with our first question. At any given point in time, what percentage of your provider data is up to date? Don't know, 25 or less percent, 26 to 50%, 50 to 75%, or more than 75%. Give yourself a few seconds to consider the question and answer choices. And once you've selected the answer that best describes where you are today, hit the submit button. I'll give you a couple seconds. Okay, so Jim, here's where we are right now. It looks like 43% don't know what percentage of their provider data is up to date. 26 to 50% say that it's up to date. 50 to 75%, 13% of that. So really the majorities are they either don't know or they're 26 to 50% accurate. That's kind of scary, but I don't know that we can honestly be surprised by that. We're going to talk about some studies that CMS has done and other information portals that will kind of validate that message. I think the most important thing is people are dialing into webinars like this and beginning to recognize whether it's the carrot and the stick between fines and penalties, but they're recognizing that they really don't have a handle on the quality of their provider directories or the provider data.
Yeah, no, I think you're exactly right. The responses are not surprising. The 26 to 50% range, I think, is probably a bigger number. But certainly, the don't know is very informative because it's sometimes difficult to measure how good is your data, what's the source of truth, how do you really go about measuring it.
Yeah. So continuing on, when it comes to managing and still reacting to vast data sources to drive value, let's dive into what it takes and what characteristics must an organization nurture. At LexisNexis Health Care, it really is all about leveraging vast amounts of individual-level information to drive value at an aggregated level. This can't be done without knowing that the data that you expect to gain value from is vast enough and from authority sources both owned and licensed, and making sure we have the analytic and technical chops to validate and manage for efficient and effective utilization. And finally, we maintain in-house healthcare domain expertise across the health continuum to provide intelligence for our customers via services and solutions. When it comes to a provider data intelligence suite, when customers can tap into our repositories of 8.5 million continuously updated entities, leveraging authority and transactional sources to ensure accuracy, then rest assured that false positives are limited via sophisticated algorithms, well, it's little wonder that when factoring in our experience and customization for integration, expected value can become more quickly realized and become realized value. But let's not forget my comment originally about redefining provided data. That often can mean gleaning information from other sources. Our claims repository encompasses claims created by providers, claims paid by payers, and claims moved by clearinghouses. The combination often provides an even richer view of the provider. So we've provided a quick but broad illumination of what you need to consider when defining, capturing, and managing provider data. Jim, let's talk a bit about gaining actionable steps for making an impact.
Thanks, Rick. Yeah, so traditional sourcing of provider data has generally proved to be inadequate. In the past, and even today with many payers, homegrown solutions or incomplete solutions are being utilized. And they often provide incomplete or incorrect data on providers and sometimes conflicts between different data sources. This slide really depicts some of the traditional data sources that were used in the industry. People can go out and get information from government websites, issue with that data, that it's not current. That healthcare practitioners are not incented to keep that information up to date. You can do Google searches on providers. Often it's going to be a one-off pull down of information. The data is good at that point in time and that point in time only. Enrollment data is also a point in time or it's current at the time you collect the enrollment. It's not updated until you re-enroll the provider. Network management operations, you get current data at the time you do the network update, but it's not updated often enough to meet CMS expectations. Provider relations react to changes that they see in the marketplace, but how do they verify that the data that they're receiving is correct? We've seen even that phone outreach isn't always accurate because it depends on who you're talking to at the practice and when you talk to them. You may get different information. How do you verify that that information is correct? Claims is another source, which can often be a good source of information, typically for the billing information on the providers. But many payers tell me that they don't trust their claims data, that it's not always accurate. Even if you put all these sources together, you're not going to meet the requirements and the expectations that CMS has for provider data. This picture is a view of a more progressive solution with many different data sources, and we know that the best practices require multiple data sources to be effective. But to do that requires very sophisticated IT operations environments, data management expertise, the ability to match and link data from disparate sources accurately to an individual, and sound business rules to determine the hierarchy of data. How do you determine which source is right or which bit of information is correct for a particular provider? A good data sourcing solution is going to start with the authority sources. So we will use a lot of those government sites, but you're going to go to specific places like the NPES file for NPI. You're going to go to CMS for Medicare exclusions and enrollments. You're going to go to the state licensing board for license information, DEA for drug enforcement agencies' credentials. Those are good sources, but it requires somebody a data steward essentially, to be looking for that data when it's updated from those sources and being able to access it, follow through, understand what's relevant to bring into your database, and then having a process for the ongoing compilation of that data, and then being able to link those bits of information to specific providers. Other sources of data are required to complete the picture, like board certification from a source like ABMS, email information, information on the IDNs and ACOs that make up the organizational side of the business. There's really no authority source for data like demographics, so in those types of cases, multiple sources are required. And to understand the best contact information, you need to be very creative. What we've found as we've been in this business is working with some of our consortium models with our customers has really been helpful in identifying change before a lot of those other authority sources may see a change. So for example, in the upper left corner we talk about pharmacy data. We have access to information at the point of sale from pharmacies, and we can identify when a pharmacy is using a new location or it's different than the data that we have, and then we can go out and verify that data. Similar with our payer consortium, as we get in files from payers and see information that payers are providing off of their master files, we can identify a change that they may have and verify that information across our other sources or direct verify that. So the idea is to really monitor the data, compile it in a very accurate way, verify, update it, and continue to repeat that process. This example happens to show an example taken from one of our payer customers that had some data on the providers, but using all of these various sources on this screen allowed us to deliver correct, current, and complete data on that particular provider and enough information to be able to update their directory. Now, at LexisNexis, we view provider data sourcing as really the foundation of any solution that we provide for delivering the best provider data that's available. Usage and delivery may take several forms. We see provider data intelligence services really as a continuum, and this stair-step approach kind of shows that. Utilizing that source of truth to deliver good provider data to match the client's specific use case and their level of sophistication. How ready are they to receive this data? Where do they need it in their organization? How are they going to use it? So the first step, well, went too far. The first step is really taking a selection or a subset of our master file, essentially a source of truth that can be used by a payer to seed a new network or for seed their environment for a network expansion, or to see a competitive view of the marketplace. So it's starting with a source of truth to be able to seed and feed your provider environment, build up your master file. The second step in the continuum is to verify, cleanse, and augment a payer's provider data to ensure that you have the most correct and complete data within your database. It provides persistent linking so that you can track a provider over time, consistently identifies information on a provider so that you can identify what information should be merged, what should be purged from your system. It provides flexibility in the frequency and the scope of what's delivered so that it matches the way your organization needs to see that data in order to consume it. The last step on the continuation is really the real-time verification. So it's being able to look up a record to verify that the information you have is correct, being able to send a query to a system and get data returned that's going to be the current and correct information on a provider so that you can start with good data at that point of enrollment or that point of verification. We've also expanded our verification into direct verification with provider practices to get confirmation of their specific payer information. But we'll talk more about that later. Rick, as you see it, what else does it take?
Jim, you've laid out a structure that I can see not only applies to the current vast dimensions of provider data ripe for analytics to impact decision making, but it can also position an organization for new or next generation focus on data excellence. It comes as no surprise to me, considering how we've looked at the industry's challenges and then the ever-changing nature of provider data, that any provider data solution must address data breadth, covering all healthcare provider types and entities. Now, we mentioned the 8.5 million provider records tracked, but let's really focus on the added advantages of having 1,500 IDNs with over 67,000 parent and child relationships, or having 1 million facility and group and other business entities, and more than 2.7 million healthcare providers and healthcare organizations. Data depth is critical. Attributes to run a business are as dynamic as possible. Going beyond address and key contact complications, we know and focus on areas including but not limited to the integrity around an individual or corporate names and doing businesses as or formerly known as, and key identifiers from licenses and status and sanction and suspect identities, and whether or not a provider is accepting Medicare or Medicaid patients. All these drive the ability to have more insight into the provider. And certainly breadth and depth are core topics of interest among health information gatherings, such as the American College of Health Executives or the College of Health Information Management Executives. But, I think, Jim, we'd be doing a disservice to this audience if we didn't at least address the importance that we, at LexisNexis, place on data aggregation and vast stores of proprietary data sources that contribute to superior decision-making capacity. Superior aggregation includes but isn't limited to 400-plus routine feeds from state license boards, data from the Drug Enforcement Agency, and board certification data from ABMS. And finally, proprietary data sources, let's not forget, in addition to the 8.5 million profiles we've mentioned, the master data files from over 60 health plans in the top 10 pharmacies, medical claims activity representing at least 60% of all U.S. claims transactions, and over 100 million provider transactional verification touchpoints per month, including that phone verification of physicians twice a year. So, Jim, what can you share specific to how customers are leveraging this data excellence?
Well, let's start by looking at a particular case study. And get the screens to advance.
I'll go ahead and advance it.
Okay.
Okay.
So this is one payer example, but it's a very similar story really across the market as we work with a number of health plans, as Rick mentioned, we have over 60 that we're currently delivering business to. We see this similar type of an approach, but this top 10 payer was really looking to reduce their risks around directory accuracy costs. They were trying to get ahead of the CMS Secret Shopper program and reduce their risk of fines. They were looking for very fast deployment. They wanted something up in 60 days to help kick off the results and make an immediate impact in their environment. And they wanted to focus on the demographic verification and provider status, which were really the key elements that they wanted in their provider directory. So what we did, at least for phase one of the process, is to provide them our provider data cleansing service. The solution allowed them to really augment their data with our source of truth information. We augmented the service with components that allowed them to integrate that data very quickly into their environment. Remember, they had 60 days to get some results. And then the phase two plan is to roll this out to a larger population. So it initially started with just their Medicare Advantage and exchange business, but they wanted to roll it out across their enterprise because they saw the operational benefit of good provider data. The result of the initial phase was cleansing their provider data that was loaded into their client master system that fed their directory system. We eliminated 9% of their inactive addresses, replaced 7% of their bad phone numbers so that we reduced their cost of processing that information, their risk of getting fined for bad data. And we also removed about 2,000 deceased, sanctioned, or unlicensed providers from the system that really didn't belong in the directory. So as I said, that was phase one. Phase two is to roll it out. And then the third phase that they're in process on now is really the direct outreach that goes to the next step in meeting CMS's expectations for communications and outreach with providers. So we have another polling question. To what degree is provider data quality and maintenance supported by specific personnel within your organization? The responses are, we know it is important, but specific personnel are not earmarked. We make do with existing IT staff, but carefully evaluate personnel each year. We try to ensure personnel are at least requested each year, or this is one of the most highest priorities, and we have specific and adequate personnel assigned to the task. Please take a couple minutes to answer the survey.
It looks like we've got, it may be limited responses because we see 60% are saying this is one of our most highest priorities, and 20% are saying we know it's important, but specific personnel are not earmarked. Another 20% saying we try to ensure personnel are at least requested each year. Now, I guess my reaction to that, first of all, I'm glad that such a large majority of the respondents say it's one of their highest priorities. I would urge organizations to make a very careful distinction between asset resources and personnel, dedicated personnel. What we see is many organizations feel like they need to create a lot of outreach phone callers and interviewers and don't think about the ability to leverage vast data sources to give them those beginning starting points and go ahead and have an online site that's pre-populated with information. What do you think about this, Jim?
Yeah, I agree with you. I think maybe if we break that question into two pieces, whether it's high priority and whether you have adequate personnel, might be two different answers there. But it tells me that there's still 40% of the market, if this survey is a good example, statistically valid, that there's still 40% of organizations that need some help. And certainly even if it's higher priority and you have staff, there's still ways to be more efficient, to be able to utilize that staff better, to have better results at the end of the day, because we know that there's a lion's share of the health plans out there struggling to meet CMS's expectations.
Yeah. So let's keep going. With the onslaught of federal and state mandates around provider directory data accuracy, LexisNexis stands ready to leverage every facet of the provider data capabilities that we offer and have discussed today to partner with you in responding to these mandates. Now, when notices come out like what was published in January saying federal officials this month warned 21 Medicare Advantage insurers with high rates of errors in their online network directories that they could face heavy fines or have to stop enrolling people if the problems are not fixed, that kind of draws a line in the sand. So a line in the sand that I want to ask you, are you ready? Because of the federal and state audit and fine activity, LexisNexis has established a solution directed at enabling health plans to leverage the breadth and depth of our own provider data in establishing a more timely and accurate and insightful methodology for ensuring their provider directories are optimized. Branded as Verify HCP, our verification of healthcare provider solution is already providing realized value in the industry. So we'll finish up this session touching upon some key points within Verify HCP. When CMS conducted a review in concert with the Secret Shopper program that Jim referred to, the results were outstanding and astonishing. Or really, were they? Only you know your organizational readiness when you talk about it. Shoppers posing as patients who could only schedule a private primary care physician appointment 30% of the time, or having 45% of Medicare Advantage provider locations in an online provider directory incorrect in a 6-month study, or listing locations without a provider physically located there, or listing providers who should not have been included, wrong phone numbers and incorrect addresses, incorrect status of physicians accepting new patients. Clearly, your customer satisfaction and likely business retention grades are at risk if your data mirrors the study data. This next slide further supports the previous. Ask yourself, in what line of your business, if any, would you ignore what 54% of your respondents indicated were extremely important or important to address? And if you did, would you be able to track that in action to subsequent non-renewals? What does it say about our industry's lagging adoption of data insight technology? Well, if quality isn't driving it, perhaps fines and penalties will. Jim, how do we help fix this?
Well, Rick, we think the best way to fix it covers several different sort of steps or stages in the process. First, you want to baseline your provider data. Now, in order to do that, what you're looking to do is to cleanse the directory information, remove or purge outdated, obsolete information such as deceased physicians or duplicate information from your system to begin with, and assign a persistent ID to your provider data so that you can track data as it changes over time and that you have a place to apply subsequent changes that you receive. So have a persistent ID connected to each provider record in your system. You want to make it easy for a provider to attest. Allow multiple ways for the provider or the office manager to attest the information that you need to have updated in your directory. Allow a provider to attest multiple payers across multiple network plans at the same time. So with one outreach, with one access point, they can update all of their information across all the plans they participate in, or as many as possible. You want to monitor your directory population. You want to check your directory for changes as changes are discovered for that particular provider. We know the requirement is that you update information that you see on providers within a week to a month, depending on the regulation you look at. But it's hard to track all of the changes that might happen, and the providers aren't always going to necessarily be proactive. So you need to monitor external sources, look at your claims, identify when you're seeing new locations for a provider, where they're billing for Medicare where they didn't bill before, and so on, so that you can then verify or submit that information to the provider to verify. And you need to employ the right technology with the ability to process data quickly and to ensure very timely updates to your data. So why is provider data so difficult? We talked a little bit about some of the industry changes, the dynamic things that occur with providers changing their demographics at a rate of 2.5% a month, 30% of providers changing their location. So data is very constantly changing. It's also increasing in its complexity. You're now required to manage whether providers in network or out of network at each individual location that they might practice at. We know that greater than 25% of providers are changing their contracting information annually, and a lot of them will change on a day-to-day basis depending on their how busy they are, how many members are seeing them at their facilities. So the complexity and the constant change makes it very difficult. Payers just are simply not set up to manage the volume and complexity of changes that we see in provider data. And the last point is clinicians are busy. So how can you do this process so that you can minimize the impact on the provider so they can minimize the impact on your members? And if that's not enough, the complexities and the constant change and the provider's busy, there are other business pressures that they're also seeing, right, Rick?
That's correct. Jim, I think the evidence and consequences are clear. CMS has and can levy fines, as can states. The threat is always there. The results I shared with you should clearly impress the risk of audit failure. Fines are expensive, monetarily and what they cost you in public scrutiny. These are the reasons why you need a partner with a solution to collaborate with you to manage your business risk. This slide further illustrates the consequences of inaction, when only 2 of 54 CMS audited directories were compliant. Letters of noncompliance, warning letters, and business plans are all becoming all too frequent first steps, and they drain you of your resources. Are you beginning to recall the saying that says, penny wise and a pound foolish lesson? Now, while California fined Anthem and California Blue Shield fines, respectively, for overstating the breadth of their network, ask yourself, what impact would having patients inadvertently going to out-of-network providers have on their out-of-pocket, on their own satisfaction? Blue Shield California was ordered to pay $38 million to their members for this unintended consequence. And we're proud of the partnership LexisNexis has forged with the American Medical Association, and we are both committed to data integrity that can directly impact quality of service provided to patients and members. The goals of our partnership are simple: to simplify the maintenance of high-quality data for use in directories, ensure patients have accurate data to make decisions, and streamline the process for health insurers, clinicians, and their practices. The reasons AMA chose to work exclusively with us extend to our experience in data management, credentialing, and understanding the critical nature of linking data assets so that analysis can be provided to improve customer decision-making. So, Jim, we're working with AMA to develop a solution to meet the mutual needs of payers and providers.
Yeah, and I think we've got a couple of slides here that kind of go through a basic flow of what we see as really best practice to meet these particular pressures in the marketplace. The flow shows a starting point of provider data coming from the payer's directory. What information do they have today in their provider directory, and utilizing or leveraging the referential database that we've built to be able to make sure that they have a good foundation or a good starting point for their data. So that data is bounced against our referential master file so that it can start out with a good, clean, correct view of the provider information. And the data that we utilize is not just self-attested data, but we're leveraging the best-in-class referential database that uses thousands of data sources, analytics, and linking technology to be able to bring together the best information to that point in the process. So once you have that starting point, we also then pre-fill information in a provider portal that allows an easy process for a provider to go in and be able to confirm or update their data. This provider portal is co-branded actually with the AMA to show its relevancy to the provider community. They know it's legit and that they know that it's something that they should respond to. It provides a very user-friendly path to quickly confirm, correct, and collect the needed information that we need from the provider for the payer's directory. CMS Medicare data requirements, as well as the exchanges and state-level elements, are all included in the portal. And the portal guides the provider or the provider's administrator, in the case of a group practice, through the process so that they can review information health plan by health plan, location by location for each provider, resulting in directory data that meets the compliance expectations. It also provides a log or a trail of the information so you can confirm what's been changed and when, and then easily integrates that data back into your environment so that you can update your online directory. We then utilize, LexisNexis also, I should say, in the process utilizes a multi-channel outreach approach that's also endorsed by the AMA to maximize the response of those outreach and to maximize the use of the portal. It also meets the communication expectations of CMS. We introduce and invite providers to the portal through each of these channels, and whichever channel works best for that provider. We utilize email, phones, and even faxes to outreach to providers. We also have trained agents that make those phone calls, receive those faxes, that utilize that same portal to gather and accumulate the information, confirm the information on the providers. And the outreach is done quarterly basis, which meets CMS requirements, as well as any of the state requirements for that matter. So the result is providing accurate directory information that goes back to the provider and is data that's continually updated as we go through the cycle of updating information on providers. Rick, what else differentiates? What else do you think differentiates our solution?
Well, Jim, I think it's been, well, my experience has been this, that as we have conversations with health plans, particularly those strictly within regulatory compliance departments, it's important to encourage a joint conversation with them and the provider network staff and the data integrity staff. Rather than merely just meeting regulatory mandates, the discussion around provider data, as we laid out in the beginning of the session, is critical. How or why Verify HCP differs in the industry? Well, I'd like to think that just by virtue of this webinar that's become obvious, but a plan is dependent upon the provider for verification to work. So we must demonstrate how Verify HCP minimizes practice disruption. And we have to be able to address federal and state regulations in one comprehensive solution. One example of being flexible and adaptable is the ability to integrate state regulations dynamically and to include plan-specific and facility attestation and a portal pre-populated for attestation, and automated claims activity analysis for non-responders and next steps. And we address and work with the physician the way they work by enabling group administrators or administration. So how are we doing? I think we're proud of the lift that we're providing, and response rates that we're tracking are pretty exciting. We'll share some of that on the next slide. However, higher than what we've seen from other published solutions, but we do see room for improvement and already are making changes to further increase the responses. And let's not forget the time savings. To Verify HCP minimizes practice disruption and is designed to take under 10 minutes to complete the first time, and it's being completely filled out and reviewed after that. It's very quick, under a minute review of the already attested information. So let's share a specific story. This is an organization that operates health plans and serves 11 million members in 29 states and offers a full range of health insurance solutions. Works with networks of 300,000 healthcare providers. Now, they were audited and they were fined. And they had no approach to attest providers at the network plan level. And state-level requirements were required for national coverage. Our approach recommended that multi-channel outreach mechanism that Jim reminded us of, flexibility to support state-specific requirements, and deploying linking and data processing, data enhancements, claims analytics, group affiliations, and consultative services. The results? Quality improved from 67 to 86%, and the response rate for outreach was 83%. These are really fantastic numbers. It's fun to see how it's evolved. Well, it's time for our third and final polling question, Jim. And it goes like this. How confident are you should your directories be audited? For instance, if CMS showed up this afternoon, how would you feel? Very confident, somewhat confident, not at all, or we've not yet evaluated our exposure. When you've decided the best answer for your organization, hit the submit button. We'll give you a couple seconds. Okay, so we've got some spread in the responses. 60% of respondents are somewhat confident should they be audited today, and 26% were not at all confident. Good to see that there is an exactly equal balance of very confident and not yet evaluate our exposure. I think the thing that I can't overestimate, one's audit experience does not necessarily prepare you for future audit experiences, particularly with the degree to which individual states are now jumping on board and really putting in stricter and stricter requirements and really looking at, perhaps making you reimburse members for going to a provider that you thought was in-network when in fact it was out-of-network, the Blue Shield in California experience. So I think it's important to stay ever vigilant in this venture.
I agree, Rick, totally. I think from LexisNexis' standpoint, our commitment to our customers is that we'll source, compile, and deliver really the best healthcare provider data that's available on the market today. We'll leverage our 40 years of experience in linking data from many different sources and analytics that bring the superior data to bear for our customers to cleanse, validate, and enhance their provider data. So hopefully be able to make it better than what you have today. And then further, we can leverage LexisNexis's robust public records data to deliver additional insights about providers and their members.
Thanks, Jim, for reinforcing those three important considerations. As I listened to your observations and thought about today, I kept thinking about what might be the unintended consequences of not tackling directories in absolutely the most efficient and effective manner. On business operations, staffing to make up for poor information and scrambling to address customer complaints over needs for the next enrollment year. On customer relations, it's never easy to explain why your information is wrong. On network operations, scrambling to cover gaps in coverages not even known. And on the bottom line, the dollar cost of lost business, the cost of bad publicity with large employer communities, and the dollar equivalent of replacing business acquisition. I think we've driven home the importance, if not foundational position, that provider data must play in supporting the health community in their top 7 dialogues. Actually, I can't help but wonder if our best laid plans in these discussions are rendered mute without the emphasis we place on provider data integrity, accuracy, and availability. Just consider, is it individual patient engagement and consumerism? It's tough to engage a frustrated customer. Evolving care payment models. Engaged providers are critical in the new fee-for-value structures. Evolving care models. Without accurate confirmation of adequate provider coverage, new delivery model contracts may well collapse. Personal and mental behavioral health integrated views. A provider's touch points across those multiple care capture systems must be aggregated. Summarize potentially avoidable conditions. This analysis is dependent upon robust and point-in-time provider data. Overall health system performance relies upon accurate provider network communication. And finally, clear attention to data use and reuse requires validation and authentication. I would argue that these challenges will determine those that will secure competitive leadership or not. The title of today's session, Provider Data Quality, Impacting Satisfaction, Retention, Insight, and Regulatory Compliance. Regardless of the market share, these are key business objectives for any organization to ensure financial viability, and each requires robust provider data depth and accuracy. For customer satisfaction is dependent upon customer experience, and nothing drives adverse experiences like when provider directories are obsolete, incomplete, or inaccurate. Business retention in this industry is critical. Given that new business acquisition costs have historically measured 3, 4, 5, 6 times the cost to retain, depending on several surveys. Nothing serves as a tipping point for large groups of business or ASO renewals as employers reacting to misinformation their employees were provided during a plan year that increased their employees' anticipated out-of-pocket costs. New insights into the degree of provider contribution to quality outcomes and performance cannot be achieved without a deeper understanding of a provider's characteristics. And finally, regulatory compliance or non-compliance is a risk organizations cannot take lightly. When margins are tight, mandated medical loss ratios leave limited room for business expansion costs. So regulatory fines and penalties associated with a provider directory audit can significantly hinder performance, let alone your public image. Well, Jim, this concludes our formal material presentation. I know we've given you a lot to consider, but I believe we have a bit of time to tackle a few questions. Jim, Mary, and I appreciate your time and attention and very much look forward to discussions with you as you work to improve the leverageability of your provider data and comply with some provider data directories. So let's take a look at what we've got in terms of questions. And I see that one of the very first questions that came in was, you referenced earlier access to payer and provider claims data. 2 slides ago, you also talked about access to ACO, IDN, and other data. I don't know that that's a question as much as an observation that, yes, in fact, our repository of both proprietary data and authority data is, as far as we're concerned, unmatched from a standpoint of volume and diversity. And so, yes, we do have claim data that can help us to have better insight into provider performance. We have payer data. We have the information around IDNs and ACOs, as well as some of the critical relationships amongst those that really help us understand the provider relations.
They really go together well, actually. So IDN, ACO, GPO information is usually from syndicated sources where that information is published. Who belongs to what IDNs or which organizations belong to what IDNs. Then you need to be able to identify the organizations. And once you have the organizations, the claims data helps you identify who bills, who works through those organizations. So you really need both data assets in order to provide a full picture of which providers are affiliated with which organizations and roll up to which IDNs.
Next question I see is, we're speaking with several of your competitors. They seem to promise the same as you. Well, we are in a marketplace that sometimes may present that. My first reaction to that is always go back to the core and understand to have a true robust insight into provider, and therefore make sure provider directory information is as robust as possible, not just meeting minimum regulatory requirements for provider directories. When you look at the repositories of our proprietary and authoritative data, it's pretty hard to imagine an organization that has similar amounts. But more importantly, let's also talk about the rollout phases that Jim talked about. And let's talk about the ability to deal with a consortium and help deal with multiple health plans with a single provider, and to be able to address how group administrators really are the fundamental backbones to getting physicians to get this attestation done. I don't know, Jim, what are your thoughts? You're talking to customers and prospects all the time.
Yep. I mean, I think the clear differentiators are that referential library that's really unsurpassed in the marketplace, which is necessary in order to audit and validate the information that you're gathering through whatever outreach methods that you're using. It provides the ability to fill in where you're not getting compliance with the providers, but also to verify the information you have and have a double check, a second way to be able to audit that information. And certainly the ability to manage provider data. We've been doing this for years. There's a level of sophistication required to be able to work through those data hierarchies and know when to update what information and how to deliver that data to the operational point of a health plan so that they can most make use of it.
Great. Another question that's come in says, it's critical to have accurate data as you clearly articulated, but what about having efficient and effective workflows to manage the processes associated with data management? Comments? Well, thank you for that question, and you're absolutely correct. It's almost like the adage of analytics. You can have all sorts of, top-notch triple PhD analytics, but if you don't know how to react to it and build it into your operational flow, what value is it? Certainly within the concept of data management and managing the processes to uncover information and know what to do with it and where to place it. We work very, very diligently with our customers, and we have for many, many years from the standpoint of how do you take this data and then operationalize it and using data management techniques such that not only you're making sure it's validated and it's clean and that it's accurate, but you're really getting it out into the workflow, the continuum of the business. Right. Jim, you on a daily basis talk about how you operationalize this stuff. So.
Yeah, I mean, I think you nailed it. You want to leverage the business expertise and how to best integrate that data within your operation. So having our staff of people implementing this type of solution over hundreds of health plans over the last few years. We've learned best practices. We've learned some of the nuances of working in different claims environments, workflow systems, and so on in order to be able to leverage this data. And we try to make our data very agnostic in how we deliver it so that you can create business rules that are customized for each environment.
Yeah. Got another question here that came in and says, is there a way to get exportable provider data? Oh, everything in my body wants to say yes. But I think the better part of valor is to say, we are a data company. We've been working with these repositories, both proprietary and public authority, for decades. We have and the reason why we've been able to build repositories of pharmacy data and payer claims data and provider data is we're very diligent about the use cases and the manner in which data is allowed to be used. So the quick answer is yes, the provider data that you would be using for information around your providers and information that you would be using in concert with our verified HCP is something that can be exported for you. Jim, take a little more. That one question could take 9 or 10 different dimensions. So.
Yeah, I mean, we should talk more about what your use case is and what data that you're trying to export for what business case, and I'm sure we can help you figure out what's the right solution for you.
Yeah. I think what we've got, we're just on the 3 p.m. mark, so we're done with our side of the presentation. So, Mary, you want to take it over?
Thank you, Rick and Jim. We really don't have any more time left. We're out of time. So we want to thank everyone for joining us today. Be sure to watch for our follow-up communication that will contain the webcast recording. Again, thank you for joining us. And this concludes today's event.